Alright, here we go. It's Endocrinology Day. It's Monday, winter 2021. It's week 4. Off we go. Diabetes insipidus. Remember last time we were talking about antidiuretic hormone, better known as ADH. And we said it's secreted mainly from magnocellular neurons in the supraoptic nuclei. In those neurons, the axons of those neurons go down into the posterior pituitary and drop this off into the bloodstream. It goes to the kidney, specifically the principal cells, causes the reabsorption of free H2O without sodium. So that's an important deal. Let's talk about some pathology now with ADH, also known as arginine vasopressin. And vasopressin is another one. So diabetes insipidus, so this is not the sugar diabetes mellitus, this diabetes insipidus. So this occurs when no free water absorption occurs in the kidney, when hypernatremia occurs. If you get salty blood, remember we said one of the strongest stimulators of the release of ADH is salty blood. The ratio of water molecules to sodium molecules is off and sodium rules. That's hypernatremia, or hyperosmolarity, or hyperosmolality. Or when hypovolemia occurs, low blood pressure can also trigger the release of ADH through the R2A system. Okay, and we recall ADH can be released, or should have been released, because of these two things, which would fix the problem by causing the absorption of free water. In a nutshell, it's caused by either ADH is not being released or properly made, by something going on with the supraoptic nuclei maybe, or magnocellular neurons, or maybe it is being made but it's not binding to the principal cells, or it's not getting into the kidney somehow. So those, and we'll go into those more in depth in a little bit. The symptoms, well, if you can't suck up free water from your urine, you're going to have too much urine. So polyuria is the main symptom. Actually had a patient over the weekend who was getting up, female, getting up 3 times in the middle of the night to urinate for the last 8 months, and not from drinking too much water. So she's probably got either a tumor in the pituitary, posterior pituitary, or a tumor in the hypothalamus, or one of the other causes which we'll get to. But polyuria, aka for that, is diuresis. That means you're urinating all the time. I could have added nocturia in here. I won't spell it out because it takes me forever to write, but nocturia, so getting up 3 times in the middle of the night is not a good thing. And then the urine, if you don't suck water out of the urine, it's going to be a water-rich urine, water versus sodium. So that's called a hypotonic solution of urine. So the urine is hypotonic. So you get a hypotonic polyuria, right? And everything I just said. And how much is too much? I mean, when do you know you're urinating too much? So typically, to make the diagnosis, you have to have at least 3, and you have to measure your urine to do this for a day. I mean, you walk around with a jug and pee in a jug all the time. But it has to be 3 liters of urine per day or more. Usually it's at least 10 liters, though, because people who drink a lot of water might hit that mark. In severe cases, it can be up to 20 liters of, not water, but 20 liters of urine per day. And that's pretty indicative of polyuria. Also, because you're losing so much water through the urine, and your blood is getting salty, your thirst centers are going to be triggered. So you're going to have polydipsia. You're going to be drinking, or you're going to be super thirsty to drink water. And in fact, that usually offsets the salty blood, the hypernatremia. The term insipidus, what diabetes Insipidus means tasteless, as opposed to diabetes mellitus. So if you actually tasted the urine, heaven forbid, which I think they had to do back in the old days, or at least smell it, it would be tasteless. It would taste like water because of the hypotonic solution. It wouldn't taste salty like it would with uncontrolled diabetes. Dangerous. Yeah, it can be really dangerous. So because of the polydipsia, well, it can be dangerous, but usually not horribly dangerous, because if you have salty blood, you're going to be thirsty, and you are going to be drinking a lot of water to compensate for the hypernatremia, and you're going to keep that under control. So usually most people have a normal level of salt in their blood. Let's see. Low volume hypernatremia is caused by chronic diarrhea. We talked about that last time. So for whatever reason, if for some reason something's wrong with the thirst centers in the brain, or you're on a desert island and don't have availability to water, you're in big, big trouble. Because then you will develop hypernatremia, and that one can kill you, make you really, really sick because of the increased osmolarity of the body fluids. Increased osmolarity causes hypernatremia or hyperosmolarity or hyperosmolality, and it can result in neurological sequelae, specifically something called hypertonic encephalopathy. Hypertonic encephalopathy. Gotta know that one. So sequelae of hypertonic, or what is it? What is this hypertonic? Well, encephalopathy, you're starting to enter the brain, right? It's some type of pathology in the brain. And what happens, in order to dilute the salty blood, the body will suck water out of the interstitium, but it'll even suck water out of the cells, including your brain cells. So particularly, for whatever reason, likes to suck water out of the brain cells. And officially, it sucks water out of the intracellular and extracellular fluid compartments. And that's not good. It destroys the brain cells. So that's not good. It can even shrink the brain, and it shrinks the cells. The blood vessels within the brain are lined with the cells we've talked about already, the same cells, endothelial cells. And when they shrink, the capillaries get too leaky, and you can get swelling into the brain because the blood can actually start leaking out, and you can get a subdural hematoma or subarachnoid hemorrhage from that. And that's not good. We'll talk about that when we talk about berry aneurysms and bleeds in the brain. But when you get blood in the subarachnoid space, it causes vasoconstriction of the other surrounding blood vessels that come into contact with the blood. And that's not good. You start getting brain ischemia and brain death, and there's a stroke. So yeah, that's the story there. So you have hyperreflexia, upper motor neuron lesion signs. I could have put that. UML signs could be in there. Seizure, coma, and death, lethargy, altered sensory function. Just those classic signs. There are actually 3 types of diabetes insipidus: central diabetes insipidus, nephrogenic diabetes insipidus, dipsogenic, super rare, but we'll talk about it anyway. Some books don't even talk about it, but there is a dipsogenic diabetes insipidus. Let's look at central diabetes insipidus. Sometimes this has some AKs here. Hypothalamic, Jameson, a medical board book there. Hypothalamic diabetes insipidus. Neurogenic diabetes insipidus. Central diabetes, or cranial diabetes insipidus. This is caused from ADH not being released for whatever reason from the posterior pituitary. So that's central, like central nervous system. Cranial, or inside the head problem. By far, this is the most common cause of diabetes insipidus. And what is the cause of central diabetes insipidus? By far the most common cause of diabetes insipidus is iatrogenic. It's pituitary gland surgery. So somebody gets a posterior pituitary or a big anterior pituitary gland, and they go in there and they damage the axons of the magnocellular neuron. And you're making ADH fine, but you can't get it down to the posterior pituitary to be released. So magnocellular neuron damage from an anterior pituitary, or it could be a posterior pituitary. But the pituitary gland is right. It's got that little stalk, and then it's got those two lobes, and then it lives in the sella turcica, a bony space. So if you develop a tumor in here, it squishes the pituitary gland. It squishes all the blood supply, and it squishes the nerves and can damage all that stuff. 9% of the time it's autoimmune attack, so that's the most common cause of kind of man-made non-tumor surgery type deal here. Then we can have a compressive tumor of the pituitary gland, or a compressive tumor in or near the pituitary, so that would be like a sella turcica tumor that compresses the pituitary and grows. So pituitary gland tumors are the number one cause. It's not usually the tumor, it's the surgery that ends up doing it. There are congenital gene mutations to this, one called familial hypothalamic diabetes insipidus. So you can have gene mutations in magnocellular neurons, and you don't make the mutation causes a defective ADH. The gene that actually makes antidiuretic hormone is called arginine vasopressin gene, and that's where arginine vasopressin comes from. The clinical presentation is going to be the same for all of these, really. You're going to have polyuria, nocturia, urine at night, and you're going to be thirsty. So definitely, remember the rule of my test writing. When I see 3 answers like this, that's prime pickings for a test question. Urine would be hypotonic. You do a urinalysis. They'll have at least 3 liters of urine a day will be coming out. And then you test their blood. They have decreased levels of ADH. And they typically have not salty blood. The blood and water ratio is fine. So that's normal natremia. So the salt levels will be perfect. That's a key word too, normal natremia. That means that the thirst centers are compensated. They're drinking tons of water a day to compensate. Otherwise, they'd have hypernatremia. Okay, then we have nephrogenic diabetes insipidus. It occurs when the kidney itself is resistant to ADH. So pituitary, magnocellular neurons, everything's fine there. You're secreting ADH, but your kidneys aren't responding it for whatever reason. We'll look at some of those regions. Okay, so the arginine vasopressin gene is not mutated in any way. Clinical presentation is the same: polyuria, nocturia, polydipsia. As long as the thirst centers are working okay, you'll have normal natremia. If they're not, for whatever reason, you'll have hypernatremia. What is the number one cause of nephrogenic diabetes? Again, it's an iatrogenic thing. It's lithium therapy. For disorders like manic depression, it's a key treatment for that. And bipolar disorder. So actually it turns out about 30% of patients who are on this lithium end up getting at least a little bit of nephrogenic diabetes insipidus because of this. How does that work? The lithium soaks in to the principal cell, gets into the gene that makes aquaporins 2 channels. Remember, aquaporins 2 are the ones that are immediately put in the luminar side of the principal cell so they can suck water out of the lumen in order to get water out of the filtrate. And so the lithium interferes with the production of aquaporins 2 channels. It's reversible once you stop the lithium, by the way. Interestingly, poorly controlled diabetes mellitus can actually cause nephrogenic diabetes insipidus. So I love that question, because you wouldn't intuitively, that sounds crazy, but it does. What's the deal with that? Turns out the excess sugar floating through uncontrolled diabetes or poorly controlled diabetes will soak into the principal cells, like all sugar does, but there's so much of it, it interferes with the implantation of aquaporins 2 transporters into the luminal membrane. So again, aquaporins 2 problem caused by excess sugar in the blood. And again, from last week's lecture, we know aquaporins 2, right? We got to have aquaporins 2, right? They're little receptors right here. Here's the filtrate. Here's the one of the collecting ducts, we'll say. Medullary collecting duct. Then we have aquaporins 2 to allow the water to flow here. Aquaporins 3 and 4 are here. They always allow water to flow out into the interstitium. And of course, in the interstitium, there's our microcirculation that can pick the water right up and get into the blood. All right, so that's the deal with that. And yeah, so you could be said that the hyperglycemia, if you have too much blood sugar all the time, makes the kidney resistant to ADH. This is the kind of the test question lingo there. There are gene mutations as another well-known cause of diabetes insipidus. Specifically, there's mutations in the gene for V2 receptors. Remember, we need V2 receptors. That's what binds ADH to the principal cells. We also need aquaporins, the mutations in aquaporins 2. So if you make a faulty aquaporins 2, you can't get water into the bloodstream. There's some regulated proteins, and some transcription factor genes, and that's getting way too far into the weeds, so we'll leave that one alone. Now this one isn't even in Goodman, which is kind of the classic medical endocrinology book. But dipsogenic diabetes, quite rare. So this occurs when there's something wrong with your thirst centers in the brain, and the patient has hyperdipsia, really for no reason. So in other words, they drink water constantly, and they just are always thirsty. And they drink so much water that it actually, the water molecules rule the blood, and the sodium molecules are well, it's not that they're scarce, they're normal, but there's just too many. You're drinking too much water compared to the normal amount of sodium. So therefore you get hyponatremia in dipsogenic diabetes insipidus. Too many water molecules around. Hyponatremia, recall, is the strongest inhibitor of ADH release. So your ADH is not released from magnocellular neurons because you're just drinking too much water. The cause is idiopathic, meaning we don't really know why some people, what the deal is. Is it a nervous habit? Is it a psychological problem? We know that people with schizophrenia, about 20% of them overdrink water. You have to be very careful with them, or they can get diabetes insipidus from overdrinking water. But there's gene mutations that have been discovered for thirst regulators where you're just always thirsty. So, but we're still not 100% sure what the story is there. Yeah, so diabetes insipidus plus dysfunctional, kind of getting back to the general theme. If you have any type of diabetes insipidus and you have dysfunctional thirst centers where you don't get thirsty, I mean, there's a time you have to have functioning thirst centers or you are going to get hypertonic encephalopathy from hyperosmolarity or hypernatremia, too much salty blood. We kind of talked about that already, but I do like to repeat myself to let it sink in. And yeah, that shrinks the endothelial cells, and you can get a subarachnoid hemorrhage and the neurological sequelae. What are the clinical findings of hypernatremia beside the hypertonic? There's other findings beside the hypertonic encephalopathy. Well, if you have too much salt in your blood, you tend to get something called, did we talk about this? Orthostatic hypotension. And that is due to the hypovolemia, probably because of the polyuria. So if you're urinating out water all the time, not only is your blood going to be too salty, but there's not going to be enough water to boost the blood volume. So this orthopedic hypotension, or just low blood pressure, is going to be the most common finding. That will occur long before any type of encephalopathy occurs. So you have plenty of time to fix this problem. If you're dehydrated too from not enough water being reabsorbed, you're going to have an abnormal skin turgor, where you can test that by pinching the forearm, the extensor surface of the forearm, or right underneath the clavicle. You pinch that skin and it should snap back flat really quick. If you pinch it and it stays bunched up for a couple minutes or even more, that's not good. That means you're dehydrated. And then if you have hypotension, your heart has to beat faster, so you'll have tachycardia. You'll probably have tachypnea as well. You'll be breathing faster as well. The board books and all books, they really leave the tachypnea out, but it should go with tachycardia as well. And then if you keeps going, I mean, you can develop the hypertonic encephalopathy, like we talked about. And the loss, what else can hypernatremia do? Well, the lost body water. This is what else can cause the hypernatremia. So it's not just ADH, but we talked about this already, right? Diarrhea, chronic diarrhea from some kind of parasite or bug that just lingers and lingers. There goes your body water. The intestines are sort of like the collecting duct in a way. They behave very similarly. Vomiting, I mean, you can lose a lot of water like that, more with the diarrhea though. Some people have overactive sweat glands that are sweating too much, or especially if they're down by the border, down by the equator. So that can be a cause of losing water. Anytime you lose free water from sweating or diarrhea or vomiting, the sodium will start to rule. You start to get salty blood, and that's hypernatremia. Diabetes mellitus, how can that cause hypernatremia? Do you guys know that one? Well, another problem with sugar, not only does the excess sugar mess up aquaporins too, but the sugar, if you have so much sugar, it can start to dump into Bowman's capsule, and it can't be taken back up. And so because glucose is a very polar molecule, it can hang on to water. You can get glucose in water in the filtrate itself. And that's the deal. It doesn't let water be reabsorbed by the proximal convoluted tubules, where most of the water is reabsorbed. So if water is paired up with glucose in the very proximal part of the proximal convoluted tubule, it'll stick to that glucose and it won't be reabsorbed. And therefore you'll lose a lot of water like that, and that will also contribute to the hypernatremia. And kidney disease, if you can't return sodium or glucose to the blood, the same thing. You start getting glucose into the filtrate, that's not good because it'll hang on to water. Fun facts, 2 most important factors needed for body water retention: ADH and a great thirst working mechanism. Those are 2 important things. What about the treatment for diabetes insipidus? There's something called desmopressin or desmopressin. There's that pressor word again, desmopressin. It's a super powerful, potent antidiuretic. It's classified as an ADH agonist. Remember the difference between agonist and antagonist? Agonist, agony, is going to put the cell in agony and make it work. An antagonist is going to make the cell turn off. Agony, if you have to start working, your cells are going to be in agony, is how I remember it. So this is a pressor agent. That's another key word. Pressor means I always think vasopressin, pressor, what does vasopressin do? Causes reabsorption of free water. So that's exactly what desmopressin does. It binds to the V2 receptors just like ADH would do, and it stimulates them, and it really stimulates them about twice as powerfully as regular ADH does. And we know what ADH, once it binds to V2 receptors, it causes the manufacturing through the central dogma of aquaporin's 2 channels. And those are put in, as I just drew a little while ago, those are put in the luminal surface, and water can rush out of the filtrate into the principal cell and rush out into the interstitium where the blood vessels are. Works best for nephrogenic diabetes insipidus. And so you could see that what the number one complication would be is it works so good that you can overdilute. You can have too many water molecules. So you develop hyponatremia, which means not enough sodium. So that's the main problem there. And if you start reabsorbing too much water, you can also get hypertension from that, and it can get really, really bad if it gets out of hand. I mean, it can cause seizures and headaches and bloating and things like that. All right, now on the other side of the coin, we have SIADH, syndrome of inappropriate secretion of antidiuretic hormone. So just the opposite. Now there's too much ADH around. So let's take a look at that. Too much ADH is around in the serum, and that's going to cause the reabsorption of too much free water, and that's going to, as we just said, it's going to make the blood water rich. So you'll have not enough sodium. So you have hyponatremic blood, or you could say you have hypoosmolality or hypoosmolarity. You have watery blood. And ADH secretion, for whatever reason, is on and can't be turned off. So what in the world can do that? There's actually 4 different categories of SIADH, which we won't get into. But the most common cause, or SIADH is the most common cause of hyponatremia or hypoosmolarity in clinical practice. So this is important with this SIADH, syndrome of inappropriate ADH secretion. You'd think they would have called it Smith syndrome or whoever discovered it, because that's kind of a long name. I mean, on boards you really have to write that out because they don't like abbreviations. Anyway, so it turns out if you go into the hospital, you're not feeling well, and they find out your sodium is really low in your blood, about 30% of the time it is from SIADH. And hyponatremia is the hallmark of SIADH. And hypoosmolarity, I mean, that one's not good either. You can quickly become fatal. So how do you make the diagnosis? Well, you have low osmolarity when you do blood work. And again, there's slight difference between hypoosmolarity and hypoosmolality, something to do with lipids and proteins. That is way beyond the scope of this class, but I mean, for most purposes, they're about the same. So if you're making too much ADH, you're going to be sucking water like crazy out of the filtrate. So the urine is going to be hypertonic, meaning it's going to be salty. So you're going to have salty urine because you're sucking too much water out of it, so you have hypertonic urine. So make sure you know the difference between hypotonic and hypertonic. Hypertonic urine is salty, too much salt, it's salty urine. Okay, excessive sodium urinary secretion. So your urine's going to be filled with salt. So what are the causes of this? So it's usually caused by some other nasty disease going on in the body. There is a hereditary SIADH where there is a aquaporin's 2 gene. It's called a function of gain mutation, where it secretes the central dogma and the machinery revs up to make aquaporins 2 channels, and it makes too many of them. And therefore, if you have too many aquaporins 2 channels, you can suck too much water out of the filtrate. So that's another cause of it. So some of these diseases, though, central nervous system diseases, like following patients who've had a stroke, are prone to over-release ADH. People with subarachnoid hemorrhage tend to over-release ADH. Meningitis patients tend to over-release ADH and develop SIADH syndrome. There are nasty tumors, so small cell lung carcinoma, sometimes called small cell bronchogenic carcinoma. That is the most common form of ectopic release of ADH. So that's another one. I mean, these are not all good things. In fact, let's go down a little case here. 41-year-old comes in with neck and back pain to your office, got a history of a cough for the last 8 months, smoker for the last 20 years. He reports urinating 3 to 4 times per night. His prostate was fine. His PSA levels were fine. His prostate was checked and fine. His blood pressure is 160/70. Obviously has hypertension. You take a chest film because of that cough. What do you think? The aortic knob is up here, a little higher than normal. Oh yeah, there it is. Boy, that one sure can be tricky to miss, right? That's a great board x-ray right there. That's not good. That's a tumor right there, right? It's not the aortic knob. That's a tumor. And yeah, so he ended up having small cell carcinoma, lung tumor, bronchogenic carcinoma, tumor in one of the main bronchi. And the tumor was endocrine. It was neuroendocrine type of tumor that secreted ADH. See how all this stuff comes together. How about some more causes? There are some drugs, again, the anti-seizure medications, the antipsychotics, recreational drug ecstasy, if people are hooked on that. That triggers the release of ADH. Desmopressin used to treat von Willebrand disease and hemophilias can also cause it. And here's the big one I save for last. The SSRIs are notorious for overstimulating the release of ADH. So Zoloft, Prolax, Paxil. Yeah, so those are other causes. Status post-surgery, anywhere in the body, the trauma can do it. Pneumonia, hyperthyroidism, these are more rare causes here, but HIV infection. So there's a lot of, that's why I put diseases in general. That's kind of the first thing you think of if somebody has overproduction of ADH. Is, oh geez, I got something else going on. There are differential diagnoses. There's some kind of similar type conditions. Addison's disease is one, because we'll learn when we talk about this more. Addison's disease, well, there's different types of it, but Addison's disease makes it so you can't secrete cortisol or aldosterone. So that's not a good thing, but cortisol is the way we shut off the production of ADH. So people with Addison's disease who they have low cortisol levels, there's nothing to turn off ADH. So ADH can be overexpressed and you can develop hyponatremia from that. And then the decreased aldosterone, I mean, that aldosterone causes the reabsorption of free water as well, but it also causes reabsorption of sodium. But nevertheless, you still get hyponatremia because you're just adding more water on top of the ADH, and there's not enough sodium to make up for the. Oh no, the aldosterone. If you don't have aldosterone, you can't reabsorb free water, but you can't reabsorb sodium. So we're already getting free water absorption from the ADH, so we're just getting pure water without salt coming in. So that can contribute to the hyponatremia. And of course, aldosterone kicks out potassium and hydrogen ions, so you can develop acidosis with this. We'll talk about that when the time comes. Clinically, how does this present? Well, do a urinalysis, and they have hyperosmolaric. They have a salty urine. They have hypertonic urine, and we know why. ADH sucks the free water out of it. And they'll also have hyponatremia. Kind of said that already. Making the diagnosis more, so you can order blood work and check this serum osmolality. It's kind of like what we said in the last slide. And yeah, so order. I guess this is what do you order. These two slides are basically the same thing. What are the symptoms? Well, you have hyponatremia. You're gonna eventually, you could get that hyponatremic encephalopathy where the body is demanding water. Or let's see, so typically only hyponatremic related neurological symptoms will show up in the disorder. So water uptake is typically not bad enough to cause things like hypervolemia or hypertension. So the neurological symptoms have been called hyponatremic. So it's not going to be sucking water out of your cells, hyponatremic encephalopathy. So you get headache, weakness, lethargy. Your brain's not going to shrink with this one though, but still, you still can have neurological deficits and seizures and coma. So kind of similar to underexpression of ADH in a way. So you can see why this could be tough to diagnose. What's the treatment? How do you treat this condition? Well, first line of treatment, if they have an overproduction of ADH and they're sucking up too much water, you restrict their water. So usually they're restricted to 1 liter of water per day. They can also take salt tablets to make up for the lack of salt in their blood. So salt tablets can do it. If glucocorticoid replacement therapy can also be the first line of defense. So that the glucocorticoids, that cortisol, that's the same. It can shut off ADH suppression as well. So that's another treatment option. And then you can work on the V2 receptors and block them so the ADH can't bind to the principal cell receptors. So there are some V2 receptor antagonists. Watch out, I like to trick you on the test on that. I'll say V2 receptor agonists. So make sure you know the difference between agonists and antagonists. All right, that's enough. See you all tomorrow.